Thank you everyone for joining us today for our NATO Hot Topics webinar. I'm Norm Thurston, Executive Director here at NATO. And so for those of you who are joining for the first time, not familiar with our Hot Topics series, throughout the year, every couple of months, we have a Hot Topics webinar, and we usually invite guests to come and talk about some latest thing, some late breaking topic. Well, turns out that there really hasn't been anything that we could really talk about over the last couple of months. I mean, HR1 is kind of a big thing, but I mean, I don't know how you talk about that in a 1 hour webinar. So what we've decided to do this time is to do something that we've always wanted to do and have never done, which is to invite our friends from other organizations who we are calling today our Friends of Health Data. And they are organizations that are involved in some degree with issues that relate to policy. And policy, of course, connects back to data. As we've talked about many times, policy and data go together. So let me just tell you who we've got today. So from the National Conference of State Legislatures, we have Erin Glossop. Erin is a policy specialist in the health program at NCSL, and her work focuses on things like commercial insurance coverage, prescription drugs, those sorts of things. And prior to joining NCSL, Erin worked for 5 years at the Ohio General Assembly, and I'm sure she misses that very much because that's just such fun. We also have the national, and I should mention that National Conference of State Legislatures is not a NATO member because you can't really do that. That's not a thing. But we do work very closely with NCSL on policy issues on a regular basis, and very good friends of ours, and a lot of communication there. National Academy of State Health Policy, also friends of ours, same boat. I am an Academy member and serve on the executive committee at NASHP. Sandra Wilkniss is the Senior Director of Behavioral, Population, and Public Health at the National Academy for State Health Policy. And in this role, she directs programs focused on adult behavioral health continuum, whole person care, state community partnerships, et cetera, et cetera. Before joining NASHP, she had worked at Families USA and spent 6 years working as a program director for the NGA Center for Best Practices. So again, great credentials, both of them, for understanding health policy, especially at the state level. And our third participant today is the Civitas Networks for Health. Civitas is a NATO member and NATO is a Civitas member, so we have a two-way relationship there. Alan Katz is joining us, and he is the Associate Director of Advocacy and Public Policy at Civitas Networks for Health. And in this role, Alan focuses on government relations to shape the future of health information exchange and health improvement. Alan has over a decade of experience representing public and private entities. So we're pleased to have Alan with us today as well. And so I think just the common theme for going to be us learning about what's on other people's minds and how we as data nerds can be helpful, and how we can reach out and make those connections, talking to our friends in these other organizations about what we can do. So with that, I'm going to go ahead and ask Erin to put her slides on the screen. And if you want to go first, that would be fantastic. And while I was talking, I noticed that we have gone well over 100 attendees, which is fantastic for us. We're very excited to have so many people joining us today. So Erin, go ahead whenever you're ready.
All right, great. Well, thank you everyone for tuning in today. I am Erin Glossop. I am a policy specialist in the health program at the National Conference of State Legislatures. And today I'll be presenting on some state healthcare cost coverage and delivery legislative trends that we are seeing. So for those of you who may not be familiar, NCSL is the bipartisan organization serving all legislators and staff across the country. And we do this in a number of ways. As you can see on the screen, we provide nonpartisan research. We host a number of convenings every year, and we also do advocacy on the federal level on behalf of the states. So who exactly are state legislators? It's important to note that for many state legislators, their elected offices are not the only job that they hold. Only a small number of state legislatures are actually full-time. The majority are part-time, and so that means they're only in session for a portion of the year. And so as a result, a lot of lawmakers hold outside employment. We did a survey in 2021 and 2022 of over 700 legislators across the country, including all but one of the territories as well. And we got a bit of a better idea of the different employment positions that they hold. So 54% of surveyed legislators held outside employment, and of the 46% that did not, almost half were retired. And you can see on the screen there, the most common occupations we found in our survey were attorneys and business owners, but state legislators can come from all walks of life: farmers, clergy, educators, healthcare professionals, and more. And this is just important to note for the sake of this webinar, because not all state lawmakers come to their state houses with built-in health policy expertise, and they may rely on folks like you and NATO, to help educate them on topics. So I mentioned in the last slide that majority of state legislatures are only in session part of the year, but when they need to come and address a certain issue, they can be called back into what's called a special session. So there on the screen, there's a map of a few states that at the time of making this presentation were in special session. Colorado also came back recently at the end of August to address the federal funding changes in HR 1, and we do expect that some other states are going to do that as well. We know that Connecticut, Utah, Virginia, and West Virginia are considering returning for special sessions, and New Mexico has called a special session in October to address the federal funding changes. So health policy hot topics. These are, this is a word cloud that NCSL has put together based on the research requests that we receive from members. So this is a reflection of what we are hearing from the states on the topics that are important to them in the health policy space. One area that stays prominent is Medicaid. This session, we've seen at least 147 bills across 29 states related to Medicaid. Workforce issues are also front and center. 45 states have passed over 620 bills related to the healthcare workforce. Affordability and access are hot topics too, especially when it comes to commercial insurance, prescription drug access and affordability, and health system concentration. And then on the population health side, we've seen states focus on topics like maternal and child health, behavioral health, youth mental health, public health data modernization, and others. So really delving into the meat of today's presentation, NCSL tracks healthcare cost coverage and delivery legislation in our database. And so this is our agenda for today's discussion, some topics that we've been tracking in our database: alternative payment models, health insurance marketplaces, consolidation and competition, price transparency, surprise billing, and telehealth. So first up, alternative payment models. This term is sometimes used interchangeably with the term value-based care, and it refers to really any value-based payment model that incentivizes providers to offer high quality and cost-effective care. And we haven't seen a ton of legislative activity on these this year. We've seen at least 3 bills in 3 states focused within the Medicaid space. But there are a couple on the screen there. So Mississippi required its Department of Health to implement a community health worker certification program and to collaborate with the State Department of Medicaid on a state plan amendment, waiver, or alternative payment model for community health worker services. And then Maryland, in its budget, created the Medicaid Primary Care Fund to really serve as the foundation for its AHEAD model, which is the Advancing All-Payer Health Equity Approaches and Development. And CMS's stated goal on their website for this model is to collaborate with states to curb healthcare cost growth, improve population health, and promote healthier living. So health insurance marketplaces, HR 1 made a number of changes to the Affordable Care Act marketplaces that are expected to impact enrollment, affordability, and continuity of coverage, as well as impact state processes, administration, and potentially budgets. And another major issue on the horizon in this space is the expiration of the enhanced premium tax credits, which are set to expire at the end of this year if Congress does not extend them. These enhanced subsidies have lowered monthly premiums for millions of marketplace consumers, and without them, premiums are expected to rise. But both prior to and after the passage of HR 1, we've seen a bit of state activity in reforming state health insurance marketplaces. We've seen at least 18 bills enacted in 14 states. And then there's a couple on the screen. So Colorado, as I mentioned, came back at the end of August to address some of these changes. And one of the changes that they made was directing funding from the sale of tax credits to their exchange subsidy program for subsidies for individuals who meet certain income requirements between 133 and 400% of the federal poverty line. And then Oklahoma this year also passed legislation granting its insurance commissioner authority to apply for a Section 1332 waiver. And just a reminder, that's the state innovation waivers under the ACA, and a lot of states use those for their reinsurance programs. And then that bill also created a fund in the state treasury for the operation of Oklahoma's state-based exchange. So consolidation and competition, amid growing concerns about healthcare costs and the effects of consolidation on the healthcare market, state policymakers are really taking a look at various ways they can strengthen their oversight of the healthcare system. So far in 2025, 19 states have enacted at least 33 bills addressing consolidation and competition. Maine, as you can see on the screen, prohibited a private equity company or real estate investment trust from acquiring a direct or indirect ownership interest, operational control, or financial control of hospitals in the state. And then Wyoming voided non-compete agreements that restricted physicians' right to practice after leaving a job, partnership, or corporate affiliation. So price transparency, due to historically opaque pricing in the healthcare sector, recently state legislators have taken action to increase price transparency across the healthcare sector. In particular, states are enforcing the federal price transparency rules for hospitals and insurance plans, as well as establishing some additional state level requirements. At least 12 states have enacted 25 bills this session related to price transparency and cost containment broadly. And at least 3 have enacted new price transparency requirements in 2025. So Nevada required a hospital to compile, publish, and update annually a list of each item or service provided for which a hospital has established a standard charge. And it also requires hospitals to compile, publish, and annually update a list of at least 300 shoppable services that the hospital provides. And Washington required hospitals to publish all data and comply with federal hospital price transparency rules. They also required hospitals to submit to the department the most recent machine readable file containing a list of all standard charges for all services and a list of standard charges for a limited set of shoppable services as well. Surprise billing. So surprise medical billing, also known as balance billing, happens when someone seeks care at an in-network facility or provider but receives services that are out of network. Many times this happens without the patient's knowledge, and it's common in ER visits, but also with ambulance service providers. But in 2020, Congress passed the No Surprises Act, which outlines several consumer protections and a payment process. But this act excluded ground ambulance services. So as a result, many states are now enacting their own surprise billing legislation to address ground ambulance services. At least 10 bills have been enacted in 9 states related to surprise billing, both for ambulance services and broadly. And you can see a couple on the screen. So North Dakota prohibited out-of-network ambulance service providers from billing more than a covered individual's cost sharing that they would have to pay if the provider was in network. And then it also set a limit on the amount that out-of-network providers were allowed to charge insurers to either the lesser of 250% of the Medicare rate or the provider's billed charges. And then Oregon specified that ground ambulance services may not bill a covered individual for covered services if the individual has paid the in-network cost sharing amount. And then it also required health plans to reimburse ground ambulance providers at either the established local rate or 325% of the Medicare rate if there is not an established local rate. And last up, telehealth. I apologize. I think you can possibly see my notes there. But during the COVID-19 pandemic, states made a lot of changes to their telehealth bills. They expanded reimbursement to additional modalities and increased access to teleprescribing. But since then, legislators have shifted towards more targeted reforms. At least 27 states have enacted 59 bills related to telehealth this year. And so a couple examples, Utah and Illinois required, Utah required any healthcare provider to obtain informed consent before providing or facilitating telehealth or healthcare services to a student in a public school. And then Illinois provided that physical therapists are allowed to use telehealth to perform an initial PT evaluation under certain conditions. And then I am happy to take any questions anyone may have.
Fantastic. Very well done. Let's see if we have, I don't see any questions in the chat. Sometimes it takes a minute for people to get thinking, but I did want to ask you, noting that, our 100+ attendees here are all in the world of healthcare data. The topics that you mentioned, alternate payment models, insurance marketplaces, consolidation, competition, price transparency, surprise billing, telehealth. What do you see the role of data programs in supporting policymakers for these bills that have already passed or states that are considering bills going forward?
Yeah, so I can't speak to a specific role. NCSL can't really, speak to a specific role, but I think that kind of question just circles back to, what I had said before, that a lot of lawmakers, they really need those resources. They need organizations that have the expertise like NATO. And so certainly, your membership reaching out to them, creating those relationships, engaging with them, that is, something that could certainly inform their decisions going forward.
And what would be, is NCSL available? Obviously you're available to answer questions for legislators, but if we had, for example, one of our health data programs had questions about, hey, what are other states doing on privacy, or what are other states doing on price transparency? Do you have resources that are publicly available?
Yes, yeah, we have a lot of resources. I'm happy to, if anyone has any questions after this call, I think my next slide has my email. There we go. I would be happy to connect anyone, that's looking for resources with some of our publicly available resources. We have a really robust library, I know in our health program, but across all of NCSL.
Fantastic. I still haven't seen any questions come in the chat. Charles, are you seeing anything, or do you have any questions that you would like to add?
I'm not seeing anything, and no, thank you.
Okay, well, we can come back at the end if we have time. If somebody has a question that you would like Erin to answer, we can come back to that at the end. We will certainly have plenty of time. So thank you, Erin. We're now going to invite Sandra to come on screen and put her slides up for us.
Here we go. Let me see. Tell me as soon as you can see them. And if I'm in sharing mode.
I'm seeing there we go, slideshow. There it is.
Are we all set? Okay,
yep,
fantastic. Set. Okay, terrific. Hi, everyone, and I'm so grateful to be here. Thank you to Norm and NATO for inviting NASHP to say a few words about what's happening in the health policy space. For those of you who are not familiar with NASHP, we are a nonprofit, nonpartisan organization. Our entire mission is to support state health policymakers, primarily in the executive and legislative branches, so in complement to NCSL as a membership organization. And our mission is to help state policymakers improve the health and well-being of all people in every state. We do that in a lot of different ways, through convening, through technical assistance, through written resources, and other mechanisms. And I'm happy to direct you to any resources or to our website as we go forward in the conversation if there's any interest in specific topics. And I will start out by saying that almost everything that I do in my lane, which is behavioral population and public health, as Norm indicated, has data as an underpinning, all the way from data collection, all the way through rapid cycle and evaluation approaches. So data, we live and breathe data, and we don't have that expertise in the way that you all do. So I'm really grateful to have this conversation, this partnership. Please reach out to me as we go forward if you see opportunities to assist state policymakers. So this slide just shows who our Academy members are and the folks we typically engage with, just so you have an understanding of grounding and folks that we talk to. We have a network for Health and Human Services secretaries. We do a lot A lot of our work is anchored and rooted in Medicaid, probably quite understandably because we're in the state space. And so we interact with Medicaid directors, their deputies, and others who are implementing Medicaid programs. And you can see the others here on the screen. Do I want to call any out? So a lot of these are folks in decision-making roles, but we also work a lot with folks who are in middle management roles that are trying to execute on projects. Okay, I just wanted to also read you in really the swath of work that NASHP is involved in. I would say that it's probably most of the health policy space that you're thinking about in your day-to-day work as you're thinking about data strategies. But just wanted to help you understand sort of how we group our work and the kinds of areas that we're working in. Aging, we have 4 big buckets of work. Cost coverage and value overlaps some with what Erin just shared with you on the NCSL side, which is really around managing costs, affordability, transforming health system in a lot of different ways. Child and family health, as it says, children and family health issues, and those are some of the issue areas that we have a significant expertise in. My area, which covers a wide swath of behavioral health issues. We also have an opioid settlement network that kind of is part of the behavioral health work. And do work in healthy communities, or what's sometimes referred to as health-related social needs or social drivers, whatever terminology fits. And that's really where a lot of the population health work comes in. With health and housing, we do work on reentry and justice-involved populations. And a number of other ways that states and communities can work together. And then we have a strong aging and disability team. There's a lot of focus on what's happening in aging. In health policy, and those are some of the topics they cover in terms of continuum of care and a real strong focus on family caregivers. Okay, so I have totally violated the rule of white space, and I apologize in advance for that. But what I wanted to leave behind, or at least to hit the highlights on and then open it up for discussion, or just leave behind for you all, is really where a lot of the conversation is among the folks that we're working with on a day-to-day basis. And these are not just in my shop, but cut across NASHP. We just came off of our annual conference, so have a pretty decent read of where the buzz is and where the conversation is at the moment. Some of these won't surprise you and others may. I tried to put in the right-hand column some data considerations for you all and how you think about your work. And of course, there's a lot more to it than that, but I was trying to signal where you might see yourself in some of the work moving forward. So not surprisingly, HR1 or OBBBA, or I've heard it called so many different things, but a big focus is preparing for implementation, especially the Medicaid provisions, but also sort of broadly speaking how HR1 is really affecting the health system landscape. The other piece of that, of course, which is the fastest moving train at the moment, is the Rural Health Transformation Fund and some of that work. As you all may know, states have applications due on November 5th. The guidance from CMS on how to apply is out. And there's a lot of focus on how best to use these funds to create access to really quality service and create efficiencies in the system and really get more resources to rural areas. On the data consideration side, all of this touches on issues of coverage in Medicaid, also in the state-based marketplaces and the commercial space. I wanted to also note that we run a network of the state-based marketplace directors, so that's a useful resource for you all if you're working in that space. And then, of course, new requirements around community engagement that will involve a lot of smart data strategies from targeting individuals to, and I probably don't even need to get into the details because you're already thinking about that. Rural health, a few of the very hot topics in the rural health space beyond just generally how to best try to leverage the Rural Health Transformation Fund. These are some topics that were key. Maternity care deserts are a very prominent topic right now among the folks we're talking to. And of course, building out not just shoring up hospital services and access to those services, but thinking broadly about the network in rural areas, primary care, behavioral health, and all the aging services and supports. What cuts across this? Of course, our access issues, but workforce. You probably have heard that many times in your health policy life. provider and community capacity building needs. That's not just individual provider entities, but thinking about networks, thinking about community care hubs and how some of those intermediaries may serve a role to really connect state health policy work with what's happening on the ground, not just with providers, but CBOs and the like. And that's a very common theme, and there are tons of data needs there, both in terms of just connecting state to community, but also cross-sector data sharing, targeting resources, doing evaluation work, lifting up best practices to really drive smart policy solutions. And a piece of that, of course, is workforce extenders. And Erin talked a little bit about what's happening in the telehealth space. There are also digital solutions, of course, on the table now, or even in the behavioral health space, new things coming online. And then AI strategies. How are those intersecting broadly with not just program development and implementation, but what do we need to know around the data and tech sides of all of that? Identifying and managing cost drivers, of course, intersect with the two areas above, and that is as states have more budgetary constraints and the Medicaid program is shifting. There's really a lot of additional thought about managing cost drivers. We have a long body of work in hospital costs. There's a hospital cost tool that NASHP has developed and shares with states and supports states around that. Of course, total cost of care approaches, things like the AHEAD model, and trying to think about how best to leverage those, and relatedly value-based and alternative payment models. And a piece of this, of course, also involves targeting resources, modeling, targeting populations and individuals for highest impact. So if you think about high needs, high cost populations, that's back on the fore as we think about program efficiencies and limited resources, how to think about data strategies to target and best serve the needs of those populations. The last thing I'll say on this slide is just a big piece of this also for internal state and cross-executive branch and legislative communication, and quite frankly, with all stakeholders and with community, is what's the value proposition? Where ROI proper perhaps, but really what is the value proposition of the kind of things you want to keep in place or dial up? What are you going to drop because it may be of low value or of low impact? And how do you understand that from a data perspective? How do you communicate that with all involved partners? A few more items here, and I don't want to go over my time, so let me just breeze through these quickly, and I'm happy to answer any questions. Of course, navigating federal policy changes above and beyond H.R. 1, states are thinking about MAHA alignment, how to align with some of the shifting priorities in the health policy space around prevention of chronic disease and other elements. And also, new executive orders, new investments, and potentially new policy strategies tied to investments coming down the pike, like block grants that may be coming in the future, and what might be happening in the 1115 demonstration space as states start to renew some of their waivers that had big elements of social drivers of health, or what was referred to as health-related social needs work, housing, nutrition, domestic violence, transportation issues. How might that change over time, and how does that change the programming and other resources that may be brought to bear for continuing some of the current efforts? And the other piece that I think you all have talked about in this group before is just changes in data collection requirements and how data are reported and disaggregated both to the federal government, but also on the state level, and where those things might be different. How are states navigating that? And then the rest are really more population-based kind of approaches. I mentioned aging and disability, and really the focus on these intermediaries and bi-directional data exchange needed to drive investments between states and locals. The aging space is where a lot of this has cropped up, but of course it also crops up in the social drivers or upstream drivers of health space. Behavioral health remains a very hot topic. Again, workforce and provider capacity issues are key, along with payment reforms that are needed to really resource a centuries-old under-resourced system. And what I'll say here is I just want to comment because I think it's really interesting. There are about 13 or more states that have invested in centers of excellence around behavioral health workforce. So all things to try to capture an understanding of who is the workforce, what are the pipeline needs, Where are there maldistributions in our state so that we can start to solve this problem? And they seem to be really getting a lot of traction and providing some good data outlets for policymakers. And then finally, in the child and family health space, big discussions around children with special health care needs, who are, of course, really high need families and children and high cost to the system, building out smart continuum of care and targeting resources. The last thing that has come up a lot over the past year is primary care. So not surprisingly, along sort of coinciding with behavioral health, there's just such a shortage and maldistribution of primary care providers and access. And there's a lot of focus on how to build out some of those strategies. We just put out a policy menu on state. So it's a guide that's based on a NAM report around policies to enhance access to advanced primary care. And it's a menu of policy options for state policymakers to pursue that. And there's some data components to that. As you can see, I could talk forever about these topics, but I'm going to go ahead and stop and just say, hopefully I gave you just put on the table where some of the hot conversations are to see how we can continue the conversation. Thank you, Norm.
Okay, fabulous. Thank you, Sandra. I don't see any questions for you in the chat. I'm going to ask you a similar question to the ones I asked Aaron. So NASHP, of course, is an academy, and then it supports states. There are no members per se. How can our NATO members use NASHP resources to further their state health policy work? How does that happen?
Oh, that's a really good question. Well, first of all, we have a website with resources, but we also run a lot of so you can use those. We run a lot of networks. Most of them are closed networks for state-only participation, not all of them though. And then we run policy academies or deep technical assistance efforts that may include a handful of states where we always need expertise. And you will know this already, every single one of those requires some data expertise, as I mentioned, anywhere along the data underpinning continuum. So part of it is us reaching out to you, knowing about you and reaching out to you in order to bring that expertise. But it also, if you see the topics that we're really focused on and you see a lane where there's some data expertise you can offer, please reach out to me, because I guarantee that we will want to know what you have to share, because that's not our expertise, but we know how valued it is. So those are some of the main ways to connect with us. And if there are individual state outreach that, where we want to connect policymakers with their data expertise, we can do that as well. So please reach out, and we're happy to make some of those connections because we know they're needed where they don't exist.
And I think it went without saying that NCSL covers all 50 states, DC, and territories. NASHP, what's your coverage? How many states?
50. Yeah. Also 50 states in DC, and we don't do work with the territories at the moment.
Okay.
Yep.
So if our friend from U.S. Virgin Islands is on, maybe he could talk to you offline about how that could change a little bit.
Absolutely. Talk to me.
Okay, we do have a question from Gevik. With all the data that is required to drive impact, what are NASHP's take on data sharing rules and consent? What are you or your views on the whole person care? So 2 questions there, one having to do with data sharing and consent, and the other one having to do with whole person care. Any thoughts on either of those questions?
Let me do my best to answer. If I don't get it right, please follow up. Okay. So in terms of data sharing and consent, it's absolutely critical. So I'll just take an example, just maybe to ground it in something concrete. As I mentioned, we do health and housing work at NASHP, which requires, and we support cross-sector teams in the health space, in the Medicaid space, in the behavioral health space, in the housing space, housing finance authorities, then also state to local partnerships between all those state entities and local public housing authorities, continuum of care, and so on, right? There are many players involved in that space. And one of the very first thing that we say to state teams when they join our work is, do you have data sharing agreements in place in order to be able to understand how to target your resources, figure out how to deliver, how to braid resources, and understand the regulatory space in each of those lanes of activity, and see how to direct the funding in a really targeted way. So data sharing Agreements are key, and understanding the legal space federally and in the state space is critical to knowing what's possible there. So hopefully that's what you're getting at. With respect to consent, I would say that in the behavioral health space, it comes up a lot, of course, with 42 CFR Part 2 and consent to share data with behavioral health providers or covered entities in that space. That can be a little trickier, and we followed the federal and state rules around that. Our view on whole person care is capitalized, so I don't know if you mean something specific, but I will say whole person care is the focus of all of my work at NASHP. We feel very strongly that supporting the whole person in a person-centered way, in a way that allows for the greatest possible connection between health, primary care, specialty care, behavioral health, and the social supports that people need is really critical, and we follow the evidence base around that in terms of our support of states. So we think it's really important. Hopefully that answered it.
All right. I hope it did too. But thank you so much, Sandra. We're now going to move on to our final presenter today. So our final presenter is Alan Katz from Civitas Networks for Health. Alan, when you are ready, go ahead and come on screen and share your presentation with us.
Thanks, Norm. And it should be loading momentarily. All right. Can everybody see?
Yep, looks great.
All right, perfect. Thanks, Norm, again for this opportunity here. And my name is Alan Katz, Associate Director of Advocacy and Public Policy with Civitas Networks for Health. Civitas is a partner with NATO, and today I will be talking about, I have a little presentation here on federal healthcare price transparency and all payer claims databases. An overview, some of the status of the policy and some of the responses of APCDs, many of which are Civitas Networks for Health members as well as NATO members. And so without further ado, get started here. The agenda, again, just very briefly, a little background on Civitas Networks for Health. Then just a very brief review of federal healthcare price transparency regulation, where it's been and where it is now. The status of price transparency and Civitas APCDs, and then APCD responses and recommendations. So what is Civitas Networks for Health? Civitas Networks for Health is the National Association of Public and Nonprofit Health Data Organizations around the country. We have full members, affiliates, and strategic business and technology partners in every state. And our core full membership include several different types of public and nonprofit organizations that manage health data infrastructure, handle health data collection and analytics, are involved in measure development or standardization, and or integrate that health data and health data functionality with the provision of care, especially value-based care, or as was emphasized earlier, whole person care approaches and methodologies on the ground. So we have health information exchanges, emerging health data utilities, community information exchanges, regional health improvement collaboratives, or RICs, APCDs, obviously, as I noted, quality improvement organizations around the country. And then we have our affiliated associations like NATO, and then we have strategic business and technology partners. And the goal of Civitas is to drive data-driven, multi-stakeholder collaboration that improves health outcomes, lowers costs, raises quality, and expands access. So, just a brief timeline here on federal hospital or it should be actually, which is not just hospital, a federal healthcare price transparency policy. Many of you may know this or parts of this already, but for those who don't, the Affordable Care Act in 2010 required hospitals and most private insurers to publicly disclose price information annually, and it granted HHS the enforcement authority to bring that into being through rulemaking. And again, there wasn't a whole lot of immediate action taken, what with the rollout and implementation of various other parts of the Affordable Care Act for a number of years. And in fact, on the state level, many states were actually leading on the hospital and health insurer price transparency front. And a lot of the groundwork was being done there, both before the ACA and in the years afterward. 2015, we had the initial HHS guidance, which was sort of very general on hospital price transparency. When the first Trump administration came into office, there was a renewed focus on price transparency on the hospital side and the insurer side as a mechanism of driving competition, as well, in tandem with a more deregulatory policy agenda. We had Executive Order 13877, which directed HHS to prioritize hospital health plan transparency rulemaking. Now, in 2019 was the Hospital Price Transparency Final Rule, which really laid the groundwork for the regulations implementing hospital price transparency, which continue to be the basis of the current regulatory regime, define different types of charges, items and services that are subject to disclosure in different types of what are called different types or tranches of service lists, and the idea of making the information available both in machine readable files or MRFs and in other consumer friendly formats. Part of the hospital price transparency rule took effect. Some parts of it were in effect immediately, but most of it did not actually enter into force until 2021, which is when the initial shoppable services standard charge requirements and machine readable format disclosure requirements for hospitals came into effect. So again, then we're in the Biden administration. 2020, just before the changeover, the Trump administration also put out the Transparency in Coverage Final Rule, which was sort of the same transparency implementation, but for health plans and insurers, requiring insurers to post, again, public MRFs, which included most negotiated rates with hospitals, allowable amounts, as well as the other big piece of it was an internet available price comparison tool, so that patients, providers, different stakeholders could compare prices disclosed on the MRFs in real time. Pieces of that became effective in 2022 and in 2023. In 2023, you had additional updates were finalized by the Biden administration to the hospital price transparency rules. Now there is now a more standardized machine readable format template for hospitals to disclose their data. There were new data elements included, estimated total prices and charging, compliance statements required from hospitals, and other enforcement changes. Essentially, this 2023 final rulemaking stepped up enforcement to a higher level than it was before and imposed some additional penalties. Most changes became effective in 2024. And then now where we are now, a few months ago in May, the Trump administration, the White House issued Executive Order 14221, which is sort of a very similar to the previous Trump administration executive order in that it really advised the federal HHS and other federal agencies with jurisdiction to pick up where the previous order left off and to continue emphasizing price transparency rulemaking on the hospital and the insurer side, and to really begin to explore additional ways through the rulemaking process and through other collaborative avenues with public and nonprofit and private stakeholders to advance the transparency mission. And that's kind of where we are now. So where we are now, in May, when the executive order was issued, there was also new guidance and requests for information from HHS, the Department of Labor, and Treasury, with jurisdiction over different pieces of this agenda on the transparency and coverage, machine readable format upgrades. So for the health insurers, you have new guidance in the form of an FAQ memo that previewed certain what they called optimizations and additional disclosure requirements for insurers to reduce data duplication and file size as key priorities to drive efficiency. The new machine readable format formatting, what they call a schema, how insurers submit this data and sort of the official templates they interact with will be available on October 1st. So this is coming up now, and they will have until February 2nd to bring their existing sort of disclosure programming and build outs into compliance. Now on the hospital side, the hospital price transparency side, there was a bit more, I would say, substance. There was a renewed emphasis on enforcement of hospital price disclosures in machine readable formats. And there was a lot of focus on standardization, the display of standard charge amounts in dollar amounts as the regulation requires, rather than as percentages, or as different sort of ad hoc formulations that were really all over the place, or that still are really all over the place, and are not really in keeping with the spirit of the hospital price transparency rules. And then there was also an RFI issued at the same time, again, focused on hospital price transparency, asking whether machine readable files are sufficiently complete in their current forms and accurate to be useful. And the answer, as I'll get into from our Civitas member all payer claims databases and others, is that the answer really is no there. And then based on the 2024 Government Accountability Office report that studied some of the issues, what needs to be done, and in particular, what needs to be done, what could inform future or additional hospital price transparency rulemaking, proposed rules, eventually final rules on the more specific and detailed standards for accuracy and completeness, as those terms are used in the current regulations. What data elements are specifically needed, what would constitute a complete machine readable file, and what additional attestations or compliance measures might be included for hospitals to adhere to in the future. So I'll just pause here. Any questions? There's a few more slides that'll focus on what APCD Civitas members and APCDs have responded to this and what their impressions are.
I don't see any questions. We've got about 4 more minutes before we're going to wrap up. So
let's run through here. Okay.
Keep going.
So APCD responses. So in putting together a response to this RFI, Civitas sought input from our APCD members around the country. We have APCDs members that are standalone, state designated all payer claims databases, and then a number of APCDs that are actually extensions or formal parts of their statewide health information exchanges in several states. And as I mentioned at the beginning of the presentation, there's some overlap. There's actually a fair amount of overlap between APCDs that are Civitas members and then APCDs that are also NATO members or NATO members. So most of our member APCDs and most APCDs in general, as we understand it, have not been using hospital machine readable files to date have not incorporated those files into their databases because of the accessibility and usability issues that have been documented. These files are, as APCDs have found, chronically disorganized, even when the data is public. It's difficult to find and correlate in one place. Data is fragmented, it's inconsistent, and it's incomplete in those areas, even where the transparency rulemaking would require it to be standardized in a certain format. It's also kind of difficult to find. Different hospitals have thrown their data all over the place, even if it's public, different parts of their website, for example. And partly because of that, there's less market demand from patients, payers, and from policymakers for hospital MRFs versus insurer and health plan MRFs under the transparency and coverage rule. And that's part of the reason why there's just less uptake for APCDs, because the disorganization makes them hard to work with, makes them less in demand, and sort of undermines the whole transparent, mutually reinforcing transparency system that way. Makes comparisons between the health plans and the hospitals on this front harder. And then I got one more slide here. And so how have, again, Civitas APCDs responded? Well, APCDs have shown and recommended, which have also been Civitas' recommendations, that the MAKE guidance about standardization in dollar figures should be, the guidance that was put out talking about dollar figures where possible instead of percentages should be standardized in regulation as part of, again, that idea of more specific definitions for accuracy of data and completeness of data. HHS should also pursue better organization of transparency and coverage data, as well as hospital price transparency data along similar lines, again, to bring them into compliance.
Called out to her. The giant sequoias hemmed her in summer.
And what other sort of components are relevant here? Well, our APCD members and partners have applauded the increase in hospital price transparency and total cost of care enforcement since 2023. That's due to basically to the government, then under the Biden administration, prioritizing it, adding some faster, more automated IT software related to the enforcement pipeline, and then adding more people to focus on this work via contracting. And we expect and would applaud similar focus or continued focus that the Trump administration is putting on this in terms of enforcement. But really the core of what we've recommended is actually, given the limited resources and human capital bandwidth, especially now on the federal level, and given that that's likely to continue consistent with a lot of the administration's focus on delegating some of these broader health and human service functions away from the federal government for the most part. This is an opportunity, especially given statewide initiatives for hospital transparency that Aaron had mentioned earlier, existing state laws, new and upgraded state laws, and state enforcement. This is an opportunity for HHS to formally partner with and empower state authorities to enforce some of the federal hospital price transparency and transparency and coverage rulemaking. They already set a precedent to do this with the No Surprises Act under Public Health PHSA Title 27 of the Public Health Service Act, which allows them to form what are called state collaboration agreements. And it's not up here, but there are 37 state collaboration agreements between the federal and state authorities to date, focused on no surprises billing and sort of a division of labor in terms of enforcing these regulations, both federally, the federal regulations and the state regulations. And this is a model that can and should be applied to hospital price transparency more broadly and health plan transparency. And I know I'm now brushing up right against the end. So any questions?
I don't see any questions, but Kristen does point out, of course, accuracy issues that self-report data frequently conflicts with other data, like the paid claims, paid rates on claims. And I mentioned this earlier, that we are going to have a plenary discussion at our conference in November discussing this issue of price transparency and comparing the tick data with other sources of data as well. But thank you, Alan. I do have just one, that leads me to my advertising moment at the end. We always make sure that people are aware of what else is going on at NATO. What's going on right now at NATO is our 40th annual conference will be November 4th to the 6th. You can see details there on the screen, but most importantly, notice that the early bird deadline is coming up soon, October 5th. We have a very generous volume discount, so if you can get 2 or 3 friends from your organization to go with you, it gets cheap very fast. And then, of course, I mentioned the price transparency panel will be one of our daily opening plenaries. So we'd encourage you to all consider attending and participating with us and with other NATO members. So it looks like we are right at about a minute to go. Sandra, Aaron, Alan, is there any last burning things that you just need to get out before we conclude?
No, just thank you so much for this opportunity, and please do stay in touch if we can connect the dots.
Yeah, and I just want to reemphasize my appreciation for all 3 of these organizations. They are great friends and partners, and I have been actively involved in all 3 of them, and I highly recommend that our members look and see what other value there is out there for you, just to make sure that we are all working towards the same goal, which is that we're using health data in a way that improves healthcare, and that involves our policy friends, our IT friends, it involves all of our different friends out there. So very, very well done. Thank you all for coming today, and we will see you again at our next meeting. Thank you, everyone.